Good morning. My name is Marie Rienzo, and I want to welcome you to the NIH Office of Disease Prevention's Methods Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar by clicking on the question mark in the WebEx toolbar. Please direct your questions to all panelists. We will open the floor to questions that have been submitted via WebEx at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 1 week. You will receive an email when they are available. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you'll be prompted to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce today's speaker, Dr. Melody Goodman. Dr. Goodman is the Associate Dean for Research and Associate Professor of Biostatistics in the School of Global Public Health at New York University. She received her BS summa cum laude in Applied Mathematics Statistics and Economics from Stony Brook University. She received her MS in Biostatistics from the Harvard T.H. Chan School of Public Health and her Ph.D. from the Department of Biostatistics at Harvard University. The National Institutes of Health, Robert Wood Johnson Foundation, Verizon Foundation, Long Island Community Foundation, Patient-Centered Outcomes Research Institute, and Susan G. Komen for the Cure have funded her work. She has over 100 peer-reviewed journal articles and 2 books, Public Health Research Methods for Partnerships and Practice, and Biostatistics for Clinical and Public Health Research. Dr. Goodman's research interest is on identifying origins of health disparities and developing, as necessary, evidence-based primary prevention strategies to reduce these health disparities. It is my pleasure to welcome Dr. Melody Goodman.
Thank you for having me. I'm really excited to share with you all some of the work that we've been doing to develop some metrics and measures for stakeholder engagement in research. There's an African proverb that says, if you want to go fast, go alone. If you want to go far, go together. And I think all of us that do community engaged or stakeholder engaged research really sort of believe and work with this principle in mind. So I'm going to give you the CDC's definition of community engagement, and they define it as the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. It is a powerful vehicle for bringing about environmental and behavioral changes that will improve health of the community and its members. And it often involves partnerships and coalitions that help mobilize resources, influence systems, change relationships among partners, and serves as catalysts for changing policy programs and practices. So we do stakeholder engaged research for multiple reasons. Non-academic stakeholders really do provide unique perspectives on the needs, and stakeholder engaged research really ensures that the patient or the community is in the center of the work that we're trying to do. It increases the relevance of research to non-academic stakeholders, whether those be patients, communities, or policymakers, and it supports the sustainability of interventions post-funding. It also builds capacity and trust among all the stakeholders working together on a project or initiative. It leverages existing resources within the community and amongst the stakeholders. It builds reciprocal relationships between the researchers and the non-academic stakeholders, and it's really been shown as an evidence-based approach to reduce health disparities. There's a need to develop infrastructure for equitable and sustainable community academic partnerships. Barriers to equitable partnerships include an unequal knowledge gap between partners and a lack of trust due to the imbalance of power and resources. Increasing research literacy among community partners and other non-academic stakeholders can really enhance the infrastructure for community engaged or stakeholder engaged research. So in some of the work they've done, Kilborn et al. Described the generations of health disparities research. And they define the first generation as the detect phase. These are studies that ask questions, do disparities exist? And then in the second generation, it's the understand phase. These are studies and programs that ask what causes disparities. And then in the third phase is our solutions phase. And these are the types of studies that are asking, do interventions work? So myself and some colleagues reviewed 1 year of the race-based healthcare disparities measurement literature. We looked at 2014 data. And what we found was that 66% of the studies that we looked at, and we looked at over 200 studies, were in the first generation. 30% were in the second generation, and only 4 were in the third generation. And so we really hope that people are sort of doing more third generation work. And I know I'm preaching to the choir with the audience today. So I really want to talk about some of our work that we've done to try to measure partner engagement. The extent to which stakeholders in research partnerships feel engaged has not really received sufficient attention. And it's important to understand how engagement level in a partnership is developing and to what extent engagement level are predictors of the larger outcomes of the study. So in the beginning, I mentioned that engagement was a way to address health disparities, but we only really have a lot of anecdotal evidence. We don't have a lot of empirical data, and we don't have really any evidence-based approaches to engagement, even though we have best practices and lessons learned. And it's really important for us to really treat engagement like a science, and build it up in a way that we can understand what aspects of engagement really impact studies as they go. So, in order to do this, our team thought it was really important to have really methodologically sound measures of non academic stakeholder engagement in research. And we've taken this approach to our study. So, we started with a systematic review, and then we did some initial development of a new measure. We're currently refining and validating the measure that we've developed. We're also working on a shorter version of the measure and are working to implement our measure in existing studies. So we first started with a systematic review of quantitative measures of stakeholder engagement. And when we started this work, we thought that existing measures existed and that they had properties that were well understood. What we found is that lots of people had measured something, but really didn't know what they had measured, and the field just was not very strong methodologically. When we did our systematic review, we found that measures came in 2 camps, the ones that are sort of out there in the published literature. The first camp is which investigators simply counted the attendance at various events and activities and assumed that that's engagement. But we don't think that that's necessarily engagement. Sometimes people show up for the pizza and the cookies and whatever else is there. They sit there in the room for the entire meeting, but they don't ever really participate. They don't really give feedback. Their voice isn't really heard. And so even though they're there, we don't know how engaged they are. And then the other type of measures were ones in which investigators measured some constructs that was possibly related to engagement, but it didn't really feel like they were measuring engagement itself. Neither of these approaches had really been validated or corroborated. Most of them had not been examined in relation to the outcomes or the progress of the project and had not been tracked over time. So just to give you a couple of examples of the counting method, some of the measures we saw are number of people who attended a board meeting, counts of attendees at a community meeting, and frequency of attendance at progress reports. Um, in the construct measurement approach, we saw people measuring things like the degree to which participants felt they were part of a community, the degree to which participants felt comfortable sharing their thoughts and opinions, and the level of confidence regarding their neighbors' willingness to participate in neighborhood problem solving processes. So because none of the existing measures had what we were looking for, we developed in a community academic partnered approach our own measure of community engagement. And it was based on 11 engagement principles that were previously developed in the community engagement literature, the patient-centered outcomes research literature, and also the community-based participatory research literature. The original measure had 36 items. There were 3 to 5 items that assessed each engagement principle. It has Likert response type options, Likert response options, and is measured on 2 scales: quantity, how much, and quality, how well. And our community partners told us that it was really important to measure both because you could do something poorly very often, or you can do something really good not so often. And so it's important to know both how much and how well things are happening. And then one of my colleagues and I wrote this sort of position paper because we thought that other people must be measuring this stuff and they just weren't publishing it. And so we sort of wrote this paper about classification, implementation, and evaluation of stakeholder engagements, and really treating it like a science and putting it in our papers in hopes that other people would start to disseminate the work that they had been doing. And as part of that, we sort of developed or really adapted this classification scheme, where we sort of put different levels of engagement. So outreach and education, we considered non-participation, coordination and cooperation. We considered symbolic participation, and then collaboration, whether it be patient-centered or community-based participatory research, we consider to be engaged participation. And I'll talk more about how our thinking of these things has evolved over time. We received funding from the Patient Centered Outcomes Research Institute to work on really comprehensively validating our measure. So we want to examine the construct validity of each engagement principle on both scales. We use the standardized Delphi process with experts, both research experts and community stakeholder experts. We've worked on examining the psychometric properties of our measure, the internal consistency and the correlative validity, which I'll talk a little bit about today. We're actually right now developing a shorter condensed version of the measure, so you guys will be the first to see some of our preliminary findings on our short measure. And right now we're in the process of doing an implementation study of people using this measure in patient-centered outcomes research or comparative effectiveness research studies. So we started with this Delphi process, and just to give you a quick background, the Delphi technique is a method for collecting and organizing informed opinions from a group of experts using an iterative process, and it's really used a lot in survey instrument development. And this approach is most appropriate to ensure that feedback is attained from all stakeholders, with all experts being treated as equal and everyone's voice being heard. We thought this was particularly important because our Delphi panel had experienced researchers, but also people who were experienced community stakeholders and some that didn't have as much experience as others, but we still wanted to make sure that everyone's voice was truly heard. And this technique really afforded us a stakeholder engaged approach to both measure development and validation in terms of construct validity. We use web-based surveys for rounds 1 through 3 and round 5, and we did an in-person meeting for round 4, which we also used some polling software. After each round, the responses of the surveys were analyzed by the investigator team. We actually stratified responses by whether they came from academic stakeholders or community stakeholders, and we returned individualized reports to each panelist that showed their individual response and then also feedback from the group as a whole. So in subsequent rounds, items where we couldn't reach consensus are provided and also with some feedback. And panelists are encouraged to reconsider their previous responses and, if appropriate, to change their previous responses in light of replies and comments from other panelists. The eventual outcome of the Delphi process for us was to obtain at least 80% agreement among experts. We did not want to force consensus, though. We really wanted to understand why consensus wasn't reached. And so for any items where we couldn't reach consensus, these were discussed at the in-person meeting. What we really found in that meeting was that a lot of this was about language and definitions, how different people define things. And so we had an editor who also attended our in-person meeting, one of the best things we've ever done. And we were able to reach consensus in round 5 on all of our engagement principle titles, definitions, and corresponding items. And mainly, I think that was because of the time we spent in the in-person meeting, working through the definitions and the language to try to get it right. So our 5-round Delphi process took us a little bit over a year. We started in late June of 2017 and we finished in August of 2018. Before each round, there was a presentation. So the first round, we did an introduction to the process and what we were really sort of wanting from Delphi panelists. And then in subsequent rounds, they received a sort of brief overview of the findings we had, where our team really had additional questions, and why we were bringing certain items and definitions back to the group. This is just a picture of the panelists who attended our in-person meeting. I just put this up because I have to give a great debt of gratitude to all of these people, and even the ones who didn't attend this meeting, for all of the feedback they gave us. We met for 2 days in a conference room with no windows in New York City in April, which is the worst time to be inside in New York City. But they were extremely dedicated and really helped us think through this in a way that we would not have been able to do on our own as a research team. So we have published our first paper from this Delphi process. We have another paper that's going to come out shortly, and we have 2 more papers that are under review. And I say that because we think it's important to disseminate our work in real time, as real time as we can. And so through our Delphi process, a couple of things happened. We started with 11 engagement principles. We modified to 8 engagement principles. We call our instrument the Research Engagement Survey Tool, or REST for short. The 8 engagement principles are focused on community perspectives and determinants of health. Partnership input is vital. Partnership sustainability to meet goals and objectives. Foster co-learning, capacity building, and co-benefit for all partners. Build on strengths and resources within the community or the patient population. Facilitate collaborative and equitable partnerships. Involve all partners in the dissemination process. Build and maintain trust in the partnership. So the first 7 were all in that initial 11. They're just modified a bit. The 8th one, we actually did not have an engagement principle around trust. And in that in-person meeting, our community stakeholders really talked about how important trust was. So that's actually a new engagement principle that was added through the Delphi process. So we also did participant surveys where we were testing various versions of our items in the field. We asked participants to sign up for sort of a cohort of web-based surveys. As you can see, we screened 675 people, 527 were eligible. Of those, about 92% actually completed the informed consent, which for us was enrollment in our study. And we had almost 400 people that completed at least one survey, and we had 324 people that completed all surveys. We released our first survey in July of 2017 and our final survey in January 2019. And you will notice that it was almost a year between survey 3 and survey 4. And that is because in that time, we also wanted to do some cognitive response testing, which was done at the end of 2018, between after the release of survey 3 and right before the release of survey 4. And we really wanted to ensure the readability and understandability of our measure, which was really important because some things came up. So even though we've been doing survey design forever, there's always some things that you just don't catch. And so there was some literacy and interpretation concerns on certain words. We were using words like dissemination and governance and intellectual property and capacity, and people just weren't sure what we meant in all of the instances that we used it. There was some confusion on the question stem, which we revised. There were some questions that really seemed complex or like double-barreled, which just not good survey design form. And also in this phase, we decided to add a not applicable option to responses just because some of the items, depending on where you are in your project, like there's some items about dissemination. Maybe your project is not there yet and they're not appropriate for you. And so we modified the measure based on this cognitive response testing, and that was what was put on the final um, survey. So, of the participants that enrolled in our study, you'll see that we've had participants from most states except for 12. Our study initially started with just recruitments in a couple of sites, which is why you see there's so many in the Midwest, because that was our first initial recruitment site. But then we really decided to expand it to more national because partnerships are so different in different places, and we really wanted to develop a measure that would be useful to the most groups of partnerships as possible. So in our participant surveys, there's 177 universities that are represented. This list just has those universities that have more than 15 participants. You'll see Washington University in St. Louis has the most. I was there for a while. My co-PI is there. We've done a lot of community work there. And then I subsequently moved to NYU, but we've also had great participation from UAB, where none of our team members are from. Northwestern was also great, Mayo, St. Louis University, and the University of Washington. In terms of the participant surveys, most of the respondents were Black or white. We did not do as good a job as recruiting Hispanics, Asians, or other multiracial races. This is also true because our instrument right now is only available in English. We really feel like it's important for us to sort of get it right in English first and then work on maybe translating it to some other languages. The majority of our participants are female, which we found is really representative of the population we were trying to reach. So we were trying to reach people who had participated as a partner in community engaged studies. And we know that females are more likely to participate in research in general, but what we found talking to lots of PIs is that many of their community advisory board members and their research partners were also female. And then most had a college degree or higher level of education, and the mean age was around 42. So one of the first things we wanted to do psychometrically is to look at if items that were measuring the same engagement principle were internally consistent. So we use Cronbeck's alpha, which is a statistic that calculated from the pairwise correlation between items, and it really measures whether several items that are proposed to measure the same general construct produce consistent responses. It's measured on a scale from 0 to 1, and values of higher than zero point 0.7 are considered acceptable in most fields. So we looked for each of our engagement principles on both the quantity and quality scales. We wanted to make sure that our items were internally consistent. We really saw Cronbeck's alpha for the most part higher than 0.8, but around 0.8 in general, which really shows strong internal consistencies, meaning that the items that we had to measure each engagement principle are at least measuring the same thing. Whether they're actually measuring that principle, this doesn't tell us that, but at least they're sort of measuring something that appears to be similar. The next thing we wanted to do is look at correlative validity, how our measure performs with other measures in the field. We use the Spearman's correlation coefficient, which is the non-parametric counterpart of the Pearson's correlation coefficient. So it's interpreted very much in the same way as Pearson's. We used ours because a lot of the results are skewed, and so Pearson's is really not appropriate in this setting. So we compared our measure to medical mistrust, the Trust in Medical's Researchers Scale, Community Engagement in Research Index, the Partnership Assessments in Community-Based Research, which is also known as the PAIR, and the Coalition Self-Assessment. These all had negligible or low correlation, even though most were statistically significant. This for us is actually really important and is exactly what we wanted. We feel like our measures should be correlated with these measures, but we're actually measuring something different. And so the level of correlation should not be super high. And then we also compared it to a measure that was developed by Kagan et al. There's the partnership self-assessment tool. There's a synergy scale on that tool. We looked at that. We also looked at the satisfaction scale of that same PSAT tool. And then Wilder et al. Have a collaboration tool. These are ones that we thought our measure was more similar with, but still different. And so we're actually really excited to see these correlations, which are all in the moderate range, still statistically significant, but showing that we're measuring something similar, but not the exact same as these measures, which is what we were hoping to see. And so initially we were thinking about how do we classify? So once we get scores from our measure, how do we classify these into different levels of community engagement? And so we were really thinking of community engagement as a continuum. And not every project needs to be in the partnership phase. I just think it's important to say. Sometimes outreach and education is where your project should be. But we still wanted a measure that would span the whole spectrum. So we asked participants on our survey to actually classify their projects according to the definitions that we provided, and then we looked at the average scores from our measure. And one of the things that is really interesting is that you'll see outreach and education was rated higher than consultation on both the quality and quantity scales, but then it sort of goes the way we think: cooperation, collaboration, partnership, all sort of in an increasing trend. And this really made us rethink how we were thinking about the continuum because of the way outreach and engagement is performing. We really thought we have to think about this with two axes. So on our x-axis, we have non-academic partner input into academic research. And then on the y-axis, we have academic researcher output to non-academic partners. And you'll see that outreach and education, while it's low on the x-axis, we think it's a little bit higher on the y-axis, which is why I was pulling those higher scores. And so it's really making us think about how we classify our scoring system for our measure. So one of the things that is sort of really important for all of us who do community engaged research is really participant burden. Our initial measure had 36 items. After the Delphi process, we were only able to get it down to 32 items. And so right now we're working on a condensed version of the measure. And we're using several methods to cut out items. So items where we found people reporting a lot of not applicable, or there's a lot of missingness, meaning people weren't responding to those items. We've also used some results from factor analysis. We've looked at the distribution of responses. We've done some item response theory analysis. We've looked at both importance and difficulty rankings from some of our qualitative cognitive interviews, and then also from our Delphi panel on their agreement and their importance rankings. And so our preliminary results show promise for a 9-item version of this measure, which is highly correlated with the full version. In some ways, that makes sense. It's using some of the same items, but it really performs well, I think, in relation to the overall version. So we are looking at just the means and just the EP-specific means right now. We have two 9-item versions of the full version that we're looking at, and just how they're performing in terms of means. We think both of them are performing really well. So this just sort of shows you for each engagement principle what the mean is on the quality scale for the two condensed versions that we're looking at, and then what the mean is for our overall, here it's called full, but for the overall measure. And you can see that both of the condensed versions show means that are sort of really similar, and so would give us really similar responses, which is what we were hoping for. We did this on both scales, so this is just the quantity scale, sort of looking at how the measure is performing overall. Our internal consistency dropped a little bit on the 9-item measure, but still over 0.9, which is great internal consistency. And then again, just looking at it at each engagement principle, how the condensed measures are performing. This is a work in progress, but we're sort of really delighted by these results. The idea that we can have a 9-item measure, we think would really still probably a lot of items for people who do surveys, but we think this could really help people and be broadly applicable in the field. So right now we're working on the implementation phase of our project. And the goal of the implementation phase is to evaluate stakeholder engagement measure in practice and examine how it's being implemented and the performance in some patient-centered outcomes research and comparative effectiveness research studies. We're trying to examine the uptake among research teams, the barriers and facilitating factors for use of the research engagement survey tool in practice, and identify any best practices for implementation. We're using the consolidated framework for implementation research, which is comprised of 5 domains: intervention characteristics, outer setting, inner setting, characteristics of the individuals involved, and the process of implementation. And we will use all this information to refine tool administration guidelines, procedures for implementing the tool in practice, and really giving us a sense of how the tool can be packaged and disseminated to research teams so that they can use it fairly easily. Our implementation study started in the end of last year. Despite being in New York City and what's all going on in COVID, because most of our work was already remote, web surveys, and phone, we're trying to move forward. As you can imagine, everyone's research is delayed as people sort of make transitions to work remotely. Um, but here's sort of where we are to date. So we sent out a baseline survey to teams that was launched in the end of September. So far, we've had 80 completed surveys, and we've had 29 teams agree to implement the measure. 20 teams are currently in the process of implementing the measure with 25 projects. So some teams actually had multiple projects that they're implementing it in. We launched the tool to those teams partners in mid-February, and so far we've had 75 completed stakeholder surveys. Our goal is to get to 300. I'll make my plea: if you know people that are doing community engaged research that may be interested in working with us to implement our tool, we're still looking for some additional teams and some additional partners to take our survey. And then those who've agreed to participate, we will do, we've decided to combine our follow-up phone interviews and web surveys and do those sort of simultaneously at the end just to get some feedback. I think the nice thing for teams that are participating is we're developing reports. If they have enough people respond to our survey, we're giving them reports. We're also giving people their own data. We're happy to share whatever we have. We're interested in psychometrics and the like, but many teams are trying to measure community engagement, so we're happy to give them as much information as we possibly can. I have a few more minutes and probably not enough to finish this whole next section, but I just kind of wanted to briefly talk to you about another sort of measure that we're thinking about. And so the first one was really about partner engagement, and the next one's really about research literacy, which we define as having the ability to understand and to critically appraise scientific research, including basic knowledge of research methodology, study design, and research terminology. And this is really distinct from health literacy, which is defined as the ability of individuals to obtain, possess, and understand basic health information and services needed to make informed health decisions. So we really think, I mean, all forms of literacy are important. Health literacy is extremely important, but especially in periods like now, it's really important for lay audiences to have some research literacy. And particularly for those of us who do community engaged work, it's really important that our partners have some research literacy so that they're able to really participate in the partnership as equitable partners. And so we've been developing some interventions for community health stakeholders and other lay audiences to increase research literacy. We run the Community Research Fellows Training Program, which is developed to enhance community health stakeholder capacity to develop equitable partnerships with academic researchers by increasing their research literacy. This was adapted from an NIH R03 that I had, and we did some work on Long Island in partnership with Literacy Suffolk. And it's really a public health methods training based on a standard Masters of Public Health curriculum. The CRIF program has been implemented among adults in St. Louis. We've had 5 cohorts in St. Louis and have trained over 100 people there. It's also been implemented in Jackson, Mississippi, and Hattiesburg, Mississippi. And in the summer of 2018, I actually piloted a version of this for youth in New Jersey. All of the other CRIF programs have been among adults 18 and older. And the goal of the CRIF program is to train community members to be good consumers of research, to understand how to use research as a tool for improving health outcomes in their community, increase community members' understanding of how to work with academic researchers, and to increase the role of minority and medically underserved populations in the research enterprise. And as I said, it's based on a standard Masters in Public Health curriculum. We modify the curriculum a little bit every year, but this is sort of the standard sessions that people take. So they learn about community-based participatory research, they learn about public health and health disparities, they learn about epidemiology and family health history, cultural competency, health literacy, evidence-based public health and program planning. We do a little bit on research methods and data and quantitative and qualitative methods. We spend a lot of time on research ethics, clinical trials, biobanking, health policy research, and then really focus on community health, community-based prevention, community organizing, and then all of our CRIF fellows, as we call them, are certified in human subjects research. So we've done some extensive evaluation of the CRIF program. We do a baseline assessment, a mid-training evaluation. We do a final assessment and evaluation. At each session, participants take a pre-test, a post-test, and a session evaluation. We do evaluation of faculty, and then we even do qualitative interviews. And all of our participants have been great and have been willing to do this, but we know that as we disseminate the program, that this is really too much of a burden for people to do. And so we've really been thinking about how do we quantitatively and sort of quickly evaluate the efficacy of research literacy trainings. So we've been working to develop a research literacy measure. Right now it's a 10-item measure. It was first piloted in our cohort 3 on their web-based baseline and follow-up assessments. We've even done some in-person cognitive interviews with them using on the measure after their training. We've modified and revised the version, which was pilot tested in cohort 4, and then we've also added this revised version to our PCORI project. And so while we're developing the partner engagement scale, we're also piloting the research literacy scale. And this is in relation to the research knowledge measure that we had been using. It started open-ended, it's closed-ended. We're also trying to cut this one down. So I'm not going to spend a lot of time talking about it other than to say that 5 of the questions were created by our research team. One question, which was on genetics and disease risk, was modified from Haga et al. That we found in the literature. And then we took 4 questions from the test of scientific literacy skills. Like I said, we did cognitive interviewing and we did a lot of testing and have been working to revise the measure. We've also done some item response theory, and we asked fellows when they were doing cognitive testing to give how confident they were in answering the questions and also telling us what they thought were the easiest questions, the 3 easiest questions, and what they thought were the 3 hardest questions. We're still sort of analyzing this data as well, but we think we have a pretty decent version of the measure, although we think definitely needs some modification and some more work the way we're doing with the partner engagement in research scale. So don't blame PCORI for anything that I said, and I just want to thank all the funders who have funded our work, including the Community Research Fellows Program, which has been funded by a variety of different sources. I have to thank all the collaborators who've worked with me, both on developing the partner engagement measure, some of the systematic review stuff, working on the PCORI grants, and also on the CRIFT program, and I'm happy to take questions. I think I actually did that in 40 minutes.
Great presentation, Dr. Goodman. Now we're going to go ahead and begin the Q&A portion of the webinar.
Okay.
So during the Delphi process, how did you manage conflicting ideas?
So we really just talked through them. So anything that was conflicting, like I said, we stratified the results by community and partner and researcher for them when they were doing the web surveys. But anything where we felt we couldn't reach consensus on those web surveys we saved to our in-person meeting. That conversation was really great, and I think really an ultimate game changer for our instruments. Because what we ultimately found were there were a lot of things that were around language and definitions. And once we were able to reach common definitions and common language, we were able to reach consensus.
Okay, great. Were there major differences you saw between the stakeholders and academic researchers throughout the process of validating the measure of partner engagement?
There were some. I think ultimately, like I said, we were able to reach pretty good consensus, but there were some issues, I think, around how academics talk about things and how community members perceive that language and what it means to them. But once we got clear around, I think, language and also definitions, what we meant by certain things. So we didn't, when we started, we didn't think we would be reaching consensus on definitions, but we found really early on that if you give someone an engagement principle and you just give them the title, that people would take that to mean different things. And so once we were able to provide definitions, I think a lot of things became clear, and it was really just around um, language and experiences, how things had worked from different people's perspective.
Have you received feedback on the measure from teams implementing it so far? And if so, how is that process going?
So we literally, like I said, we literally just launched the measure in mid-February, so we haven't received feedback from the teams yet. We will do that in a bit. It was going okay, and then COVID-19 happened, but I think that's true of everyone's research. And so there are teams that who originally signed on that are now saying they can't participate just because of the burden of work that they already had. So I think other than COVID-19, things were going really well, but I think this is a transition that everyone who's doing research right now has to make. And lucky for us, we were doing web-based surveys and telephone interviews, and so we can continue. As I think once people get back up and running remotely, then we'll be in good shape.
Okay, great. How do you see research teams using this measure of engagement in the future, and what are the goals of research teams using the measure of engagement?
So I think teams can use it in multiple ways. If you're starting a new partnership, you might want to use it longitudinally, like in the beginning, and then maybe a year in or two, and then 2 years in, just to sort of see how a partnership is progressing over time. Ultimately, we were developing it for our own work because we wanted to know, does engaging stakeholders really improve our science? Does it help with recruitment? Does it diversify recruitment? So we want to look at it in relation to a bunch of other outcomes. So we think there's a variety of ways in which teams can use it. A lot of the PCORI teams are using it because they have to measure engagement as part of what they were required to do, and I think this is an easier way for them to do it. But we think this is broadly applicable, and we think it's applicable to patients. If your partner is health systems or hospitals or health departments, we think it's applicable there. So we actually see people using it in a lot of different ways, and we've had lots of people sort of pick it up as we've been putting it out. So I think people are using it a fair bit.
What are the major differences between the research literacy measure and the research knowledge measure?
So the research literacy measure, so the research knowledge measure basically asks about one concept in each question, where the research literacy measure is more of a sort of like a midterm versus a cumulative final, if that makes sense. So each of the questions are asking about multiple concepts in one. So, there's some strengths and advantages to that. So people may know some stuff and still get the question wrong, whereas the research knowledge measure is really sort of one topic in each question.
Okay, got it. And this is one of the last questions. Do you see the research literacy measure being used broadly, or is it more intended as a measure of the CRFT or as a program similar to it?
Actually see it being used more broadly. There's a couple of other people that have been working on measures of research literacy. I've seen some in nursing, not much in public health. But I think if you're really trying to engage partners, and these are not people that you've worked with before, it is something that you may want to consider thinking about is like how knowledgeable about research are they before we get started, and what can we do to build their capacity so that they're able to partner with us in a more meaningful and substantial way. So I do think it has broad application. That was the context in which why I was developing it, because all of the things that I do are generated from real issues or problems or things that I'm trying to evaluate. But I definitely see that it could be applicable outside of the program evaluation and CRIF evaluation that we've been doing, and probably even used on some research studies. We put it in our PCORI project because we think research literacy may be a confounder of research engagement.
Thank you so much for your presentation, Dr. Goodman, and thank you to everyone who participated in today's webinar. As I mentioned at the beginning of the webinar, we will be posting the slides and a recording of today's session on our website next week. You'll receive an email with the link to the recording when it is available. Thank you.